Good morning, everyone, and welcome. Welcome to our team webinar number 1. We'll be talking about practical PREMs, and that's patient-reported experience measures. This is the first webinar of our PIN maternal equity bundle in keeping and progression of our hypertension and hemorrhage bundle. With that said, we can go to the next slide as we go through a little housekeeping for everyone. So please type in your name and institution into the chat. Let's keep ourselves muted when not speaking, and then you can raise your hand or also feel free to unmute when it's time for question and answer. And we're recording the session as always, and they'll be available to you afterwards on PinQuin's website. Next slide. So today we're going to review our baseline data. So we're excited to have data presented from a few of the teams that have joined. We have 14 hospitals of 40 that have joined the maternal equity bundle. We'll review that data, and then we'll have a presentation from Lindsey Renner and her team at TeamBirth on how they have also implemented a practical PREMs or patient-reported experience measure within the work they do in TeamBirth, and also hear and learn a little bit more about what TeamBirth is. Then we'll talk briefly about creating an equity goal for your teams, and then wrap up with announcements. Next slide. Here's our team, the PinQuin Maternal Equity Bundle Work Group. I want to say thank you, as always, to everyone that is supporting, adding their input, adding their feedback. The only faces you don't see included on this slide are those of you guys that are part of this work as well, because this is one large team collaborative effort. Next slide. And so here's our geographical outlay of where everyone is. And you see it's common that we often see a lot of our hospitals are clustered around Boston. One of the goals is that we have spread across the entire state of Massachusetts. So if there are sister or partner hospitals that you work with, or others that may want to become involved, happy to help onboard and bring others on. We have a good spread across Massachusetts and can also continue to support others as they join the maternal equity bundle. Next slide. Okay, so let's go over some of the data that we first received. And as you all that are joining the bundle continue to have a little bit more time, we'll bring in more of this data and present every month at the beginning of each webinar and show where we are. And to a degree, a lot of this will be baseline data for a while, because we'll be working together to really start to achieve some of these structure measures. So as always, with our bundles, the submission, you'll get a link, a red cap link from the Betsy Lehman Center, and that link has your measures. It's due on the 10th of each month to complete that survey. It assesses your structure and process measures. We provide the outcome measures on your behalf. It can be completed by your OB or MD, RN, midwife, champion, or your data QI staff. And each hospital that submits data has to have a signed memorandum of understanding with the Betsy Lehman Center. You'll be hearing more about MOUs from the Betsy Lehman Center, as it's about time for us to renew our MOUs with most all hospitals. Next slide. So here we have a new version of how you're entering your data. When we ask questions around your structure and process measures, the answers used to be not started, in progress, or fully in place. Now the AIM national organization has implemented a new Likert scale format so that we have more nuance and ability to answer the question a little differently. With the Likert scale, for every measure, we have given you guys an appendix that allows you to see what would be an answer for number 2 or an answer for number 3, and you just see if what your sense of 2, 3, and 4 matches with what we would use for what we've given you guys for guidance. So this is our new way of doing it. Everyone within the AIM organization and programs, all the different 47 states across the country using AIM, are using this new Likert scale format. Next slide. So let's start with our structure measures, and actually we'll stick only with our structure measures for now, because we want to hear from our guest speakers, but you'll find it interesting to see what we've learned from just the structure measures alone, and then we'll get into the process measures a bit at our next meeting. So we've had 7 hospitals respond with their baseline information for September. And the first question of the structure measures asks, do you have a formal equity team based in obstetrics or reproductive health? And one of those 7 hospitals said that they had a formal team. Now, when we ask that question, the first answer is either yes, no. And if it's yes, then we'll go on to ask questions about whether or not your formal equity team has representation across all the different types of people who are on a healthcare team. That's your nurses, your physicians, your midwives, and other social workers, et cetera, on your team. We also ask the question, does your team have a diversity of race, language, et cetera, on the team as well, so that you have that diversity of thought and information to help support your equity team? And then the third thing that we ask is anyone on your team that represents the community, especially the community that's most impacted by any disparate outcomes that you see in your clinical outcomes? And so whether that would be someone who speaks a different language, someone who's geographically far away, or racial and ethnic group. So we can see that we're all starting around from the same place, that our structure measure around forming an equity team is a hurdle many of us have to overcome. And we're doing this here also in the hospital where I work. Forming an equity team has been a fun thing, but it also is a change, and change in hospital practice. It takes effort, leadership, and support. Go to the next slide. So the second question asks, have you created and communicated obstetric equity goals? And of the 7 hospitals, 2 have responded so far that they have an anti-racism statement. Another way to demonstrate your equity goals and to communicate that either internally facing or even outwardly facing toward your patients and community would be an anti-racism statement. But also internally, you can have change concepts that you might have created from a driver diagram or a fishbone diagram. You can also have created your SMART aim statement toward equity. And one hospital reported that they have started a SMART goal or an aim statement toward equity. So many of us are still in the process of outlining what our equity goals are and putting that in a space and in a visual that allows everyone in our unit, on our units and in our institution, to know what our goals are and what we're working toward, particularly in the short term. The beautiful thing, as we know about SMART goals, is that they are specific, that they are measurable, that they're time bound. And those are some really important key points of this. So that way, as you're doing this work, people can see where you are. And then with run charts over time, we'll talk about run charts in the future, you can continue to show people in your unit where you're going. Go to the next slide. The third question asks a question around demographics. As you collect data within your hospital system, do you collect data that helps you to understand who is differently abled? The race, the ethnicity, gender, language, as well as sexual orientation. And so among those 7 hospitals who responded, all collect race and language data. I don't think there's a surprise there, and we're really happy about that. 5 collect ethnicity data. I was a little surprised that it wasn't race, ethnicity, and language. And we can learn from each other as to what the challenge would be around ethnicity data. And all are at varying degrees, varying stages of collecting the remaining, whether we're collecting information on differently abled, or sexual orientation or gender identity. So we know that there's been a lot of movement in that space, particularly in some hospital systems, to change that system of collecting information so that it shows up as self-identifiers within our medical records. And that becomes very important for the way we communicate with our patients and understand what the needs are. So we'll go to the next slide. And here, among those who are currently collecting that demographic data, this is sort of the part B to that question. The question asks, was that data self-reported? And so we see that the majority do collect this via patient self-report. Next slide. So our 4th structure measure asks the question, well, do you disaggregate? Do you stratify that data by age, race, ethnicity, levels of ability, gender identity, not ethnicity, and sexual orientation? And we see that all reporting hospitals in September have not yet started that process for all of those areas. We do have some who are showing to be working on it in some level of early level of progress, but many are still at the not yet started stage. So that's about us working with our hospital systems to understand how data is collected and how data can be stratified. And within our own systems, that becomes very important, because when we're looking at clinical outcomes like hypertension, hemorrhage, cesarean birth, we want to understand who is represented in the groups that have the outcomes that vary and are no longer in with the rest of the group where we want our goals to be. And so that would be those who are having higher rates of cesarean when they could have lower rates of cesarean, or those who have higher rates of not being treated for hypertension within a timely fashion, or are they with the group of where we have our goals set? So it becomes very important. So this is really nice for us to spend some time working on, and we'll have some information on how hospitals have done this and done this well when we have our summit this spring. Next slide. So our patient number, our structure measure number 5 asks the question regarding what we're going to talk about today, and that is PREMs, or that stands for Patient Reported Experience Measure. And you'll hear me say that often. I say it, and I say it slowly often, because there's a number of 4-letter, 3-letter acronyms within medicine. And PROM, we often hear patient reported outcome measures, but we're talking about patient reported experience measures. So how do we take in information on how patients are experiencing their care? And among the 7 hospitals that answered this question, 3 have not yet started that. However, 4 are in some level of establishing a PREM. And with that, as we turn the microphone over, we'll go to the next slide. Soon we'll turn the microphone over to TeamBirth. We'll hear about how PREMs is implemented there with those teams. So let's take a moment now to, stretch our arms for a second. I know we're all on Zoom and everybody's having busy days as usual, but let's take a poll question so that we can see where everyone is. So the question here is, which structure measure are you working on or working to complete presently? Which is the one that's really at the top of mind for many people? And it could be a lot of people are working on more than one, and we're giving you a single choice here. So we're trying to see what's sort of taking most precedence for teams. So while we're collecting the responses, I'll ask again for our housekeeping for everyone to put in your name and your institution in the chat. Welcome, welcome for those who have just gotten on with us, and for those who've joined after we made the announcement to put your name and institution in the chat, but please do that. And we're in the data review portion of the discussion today, and then we'll be moving on into discussing TeamBirth's work with us as well. Terrific. So among those on the call today, we had 59 or 60% respond, and it looks that the majority, or 42%, are working on creating their formal equity team. 24% are working on their equity goals, 32% are working on data collection, and 3% on PREMs. So we'll keep this in mind, and we'll ask this question again and see sort of how we're progressing over time. Are we able to see the results?
Yes.
Oh, terrific. Great. Well, I'd like to pause here and take a moment to turn it over to our partners in addressing maternal equity and our partners in addressing maternal outcomes and supporting patients in their experience of care. And that is those from Ariadne Labs who work with the TeamBirth, and that's Lindsey Renner and Trisha Short. So I will pause here and turn the microphone over. Thanks for joining us today, guys.
Fantastic. Thank you so much, Audra. And hello, everyone. It's nice to, I saw some faces at the beginning. I think my view is a little bit different now. Oh, there we go. I see faces again. But it's nice to see you all. My name is Lindsey Renner, and I'm a research assistant at Ariadne Labs. And I'll turn it over to Trisha just to quickly introduce herself as well.
Hello, my name is Trisha Short. It's lovely to get to be here with your teams, and we're excited to talk to you more about PREMs and what that looks like in the TeamBirth pathway.
Yeah. So next slide. Yeah, so like I said, we're from Ariadne Labs. This is just an agenda of what we'll go through, but we'll go ahead and get started. So next slide. Next slide again, sorry. So we are on the Delivery Decisions Initiative at Ariadne Labs, which is a social impact program that focuses on designing, testing, and spreading innovations to promote quality, dignity, and equity during childbirth. Next slide. Here you can just see members of our team. You can see Trisha and myself, our phenomenal director, Amber Wyseth, who I know many of you have interfaced with, as well as some others. Next slide. And here's just some statistics that everyone on this call is well aware of. Today's maternal mortality crisis in the US, a crisis that disproportionately impacts people of color, and just statistics around the research that shows majority of these pregnancy-related deaths may be preventable. And I know the CDC recently published some research showing that they actually think that that statistic is higher, around 84%. And on this slide, I want to draw everyone's attention to that bottom statistic there, because this is what we really try to get at with TeamBirth, that 80 to 90% of reported sentinel events are due to failures of communication and teamwork. So if you go to the next slide, I'm just going to provide a high-level overview of TeamBirth because many of you are either familiar with it. There are a number of individuals from sites on this call that are actually about to start implementing TeamBirth. So just a high level to provide context so that you understand how we use PREMs to evaluate the impact of this initiative. So next slide. So you see here the purpose of TeamBirth. It is a care process innovation. I'll go into the core components in a moment, but it's really designed to promote shared communication, teamwork, and patient-centered care. It does so by bringing patients into the conversation, providing a structure that is easy to understand and participate in, as well as a visual model for patients to see so that they know they can see the record of the conversation that has occurred, changes to their care plan, all the decisions that have been made. And then for clinicians, TeamBirth encourages conversations to be had with the patients at their bedside to promote open lines of communication and shared decision-making. Next slide. So like I said, TeamBirth, it's a simple solution. It's based on these two design principles of teamwork and simplicity, all used to promote these four core behaviors, which is promoting each member of the care team, eliciting patient preferences, distinguishing the plan for the birthing person, the baby, and labor progress, and then setting expectations for when the entire care team will come together again to huddle. Next slide. These are our two core components. So team huddles, you can kind of think of them as more structured bedside rounding, but it's bringing those conversations that may be occurring more often, say in the hallway or at a nurse's station. It's bringing those into the room beside the birthing person, involving them and any support persons that are in the room. And it's all structured around this shared planning board. So if you go to the next slide, these are two versions of the shared planning board, one that's utilized during labor and delivery and one during postpartum. And it is designed in 4 quadrants that all correspond to the 4 core TeamBirth behaviors. So identifying the team, birthing person's preferences, plan, and next assessment. And it's really used both to structure the conversation as well as to provide that visual space for a patient and the care team so that they all are on the same page in terms of the plan of care. And with that quick high-level overview, I'm going to turn it over to Trisha, who's going to talk through how we actually evaluate the impact of TeamBirth through PREMs.
Excellent. Thank you so much, Lindsey. If you don't mind advancing to the next slide. First, just what is PREMs? And Audra already did a really great job kind of laying this out and explaining. But patient-reported experience measures, we utilize validated questionnaires that really gather the impact of care from patients and their families. So we cannot change that which we do not measure. So really understanding the patient experience is a critical component of TeamBirth to really understand its impact. You can go ahead and go to the next slide, please. So I'm going to tell you about our journey of PREMs and really the TeamBirth journey of PREMs. The TeamBirth design was created in 2017 after a great amount of literature review, but really also engagement with professionals, obstetricians, midwives, doulas, patients, nurses, to create a solution really for what Lindsey had mentioned, that breakdown in teamwork and communication. How can we help design a solution, a simple solution to solve for that? In 2018 and 2019, we had our pilot trial of the TeamBirth in 4 hospitals all throughout the United States. 2 were located in Washington State, 1 in Tulsa, Oklahoma, and another in Massachusetts. During that time, it was an acceptability and feasibility trial where we were just wanting to really understand, did patients like this model of care, and did clinicians like it, and would they do it? What we did learn from that trial is that our metrics for measurement were not ideal because we weren't using validated tools at that time. So from that, we learned a great deal, and we went on this new journey with the second round of our pilot trial to really understand the better assessment of patient experience measures from the impact of implementing TeamBirth. With that, we utilized and added some exploratory questions from the labor agency scale, from the satisfaction with childbirth experience questionnaires, and women's perceptions of control during childbirth. We can advance to the next slide, please. After our initial pilot trial, we had the opportunity to really shift gears of what we were trying to measure and understand through the TeamBirth impact. And that's really, we wanted to focus on inequities and experience for Black birthing people and vulnerable families. So is TeamBirth a solution for everyone, or is it just for a small population of people? And so in doing that, we really set out on a journey to understand what are better measurement strategies that we could deploy to gain that information. And where we landed was MADAM, Mother's Autonomy and Decision-Making. And how we came to that solution was for actually a couple of reasons. We met with Dr. Saraswati Vedam out of the Birthplace that's located in the UK. We had convenings with her to understand the development and strategy behind that scale. The other compelling piece to that is it's a 7-question survey, which, as you know, sometimes it is a daunting task to ask so much of our patients in that postpartum period to do surveys. We can go ahead and advance to the next slide. So as mentioned, the MADAM scale was developed by a team of researchers at the Birthplace Lab in British Columbia. It measures a single construct, which is really around the autonomy and decision-making for maternity care. And what we're really trying to study and understand is the woman's ability to lead decision-making. Do they have the information that they need to understand the risks and benefits, the pros and cons? Do they have the time to make a decision? What I do want to pause and say very notably is that labor and delivery, postpartum, there is care within that we provide that's very black and white. When you have a category 3 fetal heart tracing and you need to go back to do that crash C-section, that's not a time to really participate in that shared decision making. But it's the gray area of all the decisions that we make in providing care to that patient that we really need to pause, slow down, and bring them along in that journey and allow them the opportunity really to speak and to be heard. And so this particular scale is really sensitive to those core TeamBirth behaviors that Lindsey had mentioned, and that's why we landed where we did with this validated tool. So we can go to the next slide. I did want to provide you just with a list of those 7 questions. So they asked how involved I wanted to be in decision-making. My doctor or midwife told me that there are different options for my maternity care. They helped me understand the advantages, disadvantages. They helped me understand all of the information. They gave me enough time to really consider my options. And finally, they respected my choice whenever I did come to that decision. So that's the list of the 7 questions from the MADAM scale. And then it is on that Likert scale. So it does provide from very low patient autonomy scores to high patient autonomy scores. And we're going to look at some of that data here in just a moment. So we can go ahead and advance to the next slide. So this is the $1 million question. How do you collect this data? If you don't mind going to the next slide, I'm going to walk you through that process a little bit. I'll tell you a little bit about my journey with TeamBirth. I have my background is nursing. I'm a labor and delivery nurse of 17 years in a high obstetric unit located in Tulsa, Oklahoma. I was on the implementation lead for our hospital here that implemented in the pilot trial back in 2018. I say all that because I had the great opportunity and privilege to really interact with patients through the surveying process. But I must say it did not come without hesitation, reluctance, because it is a big job. It does require time, but the impact and value it brings was so powerful that it was easy once we got it started to continue going. So how did we do that and what does it look like? The patient survey process, really there's two options. One is the QR code. For whatever reason, nationally, we have really low participation when we deploy the QR code strategy. Whenever we collect that data, we get about a 15 to 30% response rate. If we transition that to paper surveys, which does require a more hands-on process, that's when we see response rates from 45, even up to 65%. So a much greater feedback in that process. So if you have the strategy already at your institution where you do manager rounding, that is a really easy way to deploy this strategy. If not, we didn't back in 2018 have mandatory manager rounding. So it was something that we had to really kind of do our own PDSA cycles around, figure out who, how, and when we would execute this big task. But again, it brought so much value and really honestly joy to the jobs of those that were participating in it that it was easy to keep it going. Once we would distribute the surveys, we would tell the patients really what was the why and the ask. Like, we genuinely care about your experience and we want to know how it was for you and what we could do to make it better. And that always seems to have like a positive impact on patients being willing to share that feedback. Once distributed, we would distribute postpartum day 1. And then we would just add for the postpartum discharge checklist with the postpartum nurses to collect or just ask for, did you have time to complete? Did you participate? It's voluntary and it's anonymous. And if they did, they would collect the survey and place it in a basket in the nurses station. We then, our team would collect that data and put it into Qualtrics. Once that data was collected, that's when we would receive back these dashboards. And if you go ahead and go to that next slide, that's where we get all this data back. And it's really when we were able to see and understand this data, we really fully understood the power, and it helped us continue to propel and implement TeamBirth. So this is just one example of really taking that data, sharing it back with your clinicians, your providers, your nurses, your quality team, but really fully understanding what is the impact of the TeamBirth intervention for your patients. We can go to the next slide. So now I'm going to tell you, I told you a little bit how we got to the journey of MADAM and that specific validated PREMs tool. I'm going to also show you now some of that research that we've collected since 2018 when we started that pilot trial. So if we go to the next slide, this is from that acceptability feasibility trial in 2018-2019. Did patients like it? And did clinicians like it, and would they do it? And this was the data that we received from that trial. High level, 97% of patients really felt like they had the desired role in their birthing experience. 98% reported that they had clear communication with providers and ability to share care preferences. And when sharing care preferences, 90% felt that it really made a difference in their care. So they were heard, and we customized care to meet their goals. And then on the clinician side, which was honestly kind of shocking to us, because anytime we start to deploy change is hard, right? So we weren't sure, honestly, what to expect, but we were shocked by how well this was received by clinical teams. So for clinicians, 93% felt that TeamBirth improved care for their patients through better communication, teamwork, and shared decision-making opportunities. 90% said they would recommend it to another unit. And 84% felt that it did provide clarity in non-urgent cesarean sections. We can go to the next slide. From that pilot trial back in 2018 and 2019, we do have 3 publications in the Birth Journal. One is on the TeamBirth design, the second's on the primary outcome, and then the third is really about the implementation strategy that was deployed to achieve this. We can share all of those articles with you if you're interested after this meeting. We can go to the next slide. So as I mentioned, the four hospital pilot trial in 2018 and 2019, there was an enormous amount of data collection. Therefore, when making the selection of those hospitals, we had to find teams that had both the will and the capacity to do that kind of rigorous research and data collection. However, once we really analyzed that data, what we found it was not very diverse or reflective of most patient populations. 50 to 80% had private insurance. They were predominantly white. We care very much about birth equity. And so the second round of TeamBirth, when we did more in-depth measurement strategies, we specifically sought out teams and hospital sites that had more diverse patient populations. Where we landed was 2 hospitals in Massachusetts, UMass Memorial and Health Alliance, and also in Tulsa, Oklahoma at Hillcrest Medical Center and Oklahoma State University's Medical School and Hospital. So this data that we're going to look at from MADAM broken down by race and ethnicity on this next slide, if you don't mind advancing. First, there's a lot to see here and a lot to unpack. So I'm going to kind of do first just some orientation to this visual. When we talked about MADAM, it's that 7-day question validated tool, and we broke it down. On the left is no huddle. So that patient reports that they did not receive a TeamBirth huddle. On the right, it's patients saying, yes, they did receive a TeamBirth huddle. And we broke it down by race and ethnicity and into 4 quadrants, from that very low autonomy, which is kind of that light blue, light white, to high patient autonomy, which is the dark blue. And that's what we desire to see. And what we see is that this is the data collection from the second round of pilot trials of implementation, is that there is an increase in high patient autonomy among each race and ethnicity category. What we also see is a reduction in that very low patient autonomy. This is unpublished data that was in the process. We are writing a manuscript, so more to come. Not published yet, but will be soon. We can go ahead and advance to the next slide. Since that, we are now working with really 77 hospitals all throughout the US, and we're moving even into a global context. But one of our partnerships is really located centrally with the state of Oklahoma. We have partnered with the Oklahoma Perinatal Quality Improvement Collaborative through the Department of Health, funded by HRSA, to deploy TeamBirth in every birthing facility in the state. And it's going to be for 3 years, 3 cohorts, and we've already started with cohort 1. And so some of this data collection I also wanted to show you, but this is specifically within the state of Oklahoma. This is MADAM again, broken down by yes and no huddle. We have not yet deaggregated this data to look at it even closer by race and ethnicity, although we are in the process of doing that, but this journey of data collection just began. So again, you can see with each question, the blue is no, the patient did not receive a TeamBirth huddle, and the green is when patients report, yes, they did receive a TeamBirth huddle. And there is, in many categories, a profound difference in their scores. So involved in decision-making increases when they have that opportunity where the team comes together, speaks with them openly, transparently, and really does provide those shared decision-making opportunities. So this is where we see an increase with the TeamBirth experience, and we'll continue to do data collection across the state of Oklahoma to understand the impact broken down by race and ethnicity, because that is really what we deeply desire to understand. We can go to the next slide. This is just another, well, it's an added bonus of data that I wanted to share with you. The Healthcare Relationship Trust Scale revised. So we have hypothesized that since the pandemic, there has been a decrease in trust between birthing people and their clinical care team. And we wanted to measure and understand, again, does TeamBirth have an impact on that trust metric? These questions are in some ways similar to the MADAM questions. There's some similarities, but really breaking it down by trust. And what we see here again is blue is no TeamBirth huddle, and orange is yes, they did receive a TeamBirth huddle. So data that we have just started collecting in June. It's really early in the data collection process. And like I said, it's a 3-year partnership, so there will be more to come. But what we are seeing so far is very encouraging. So I just wanted to, that's the cherry on top that I thought I would just go ahead and share with you. With that, we can go ahead and go to the next slide. And this honestly is my favorite part, and maybe shocking for our teams, because what we see is that patients are so eager to share their feedback, the good, the bad, the ugly. They really take the time to write and share vulnerably and in depth their experience. And so from deploying these PREMs surveys that we do with TeamBirth, we also leave a qualitative space on the back of the survey for patients to write and share any information. And this is really where you have the power of understanding the experience that you've provided for this patient and their family. And we do give these comments back to their teams because it really does powerfully impact and propel the implementation. People get the, okay, now I understand why we're doing what we're doing when they get to see, read, and hear these comments. I'm not going to read them all. There's 8 total that I've put on here. But I wanted you to be able to see them and refer back to. Things that I think would be worth highlighting is some of the bold areas. So I'll go ahead and do that. The entire team ensured me and my son were well cared for before and after delivery. My doctor respected and supported my decision for my birth choice and safely delivered my son. After labor were exception and should be commended for their compassion, knowledge, and kindness. We were provided the most unbelievable level of care. It was a very difficult induction and then C-section delivery, and each team was amazing. What I love about that is it's clear to understand that this particular birthing person transitioned from a trial of labor to a cesarean section, but still had gratitude and was pleased with the outcome. L&D nurse made us feel so much more comfortable in everything, and we always felt we had an extra advocate for us because she took the time to re-explain the benefits and risks to everything we did. So really taking the time to help them understand and come along in that journey. What we have heard from patients is when we anchor that information on that shared planning board, that really does provide that closed loop communication, because patients don't often and always understand fully what we are recommending or what we're saying, and they need time to digest that information. And by anchoring that information on that shared planning board, it gives the opportunity to do so. And then this one says, amazing in explaining things during my induction and listening to my concerns or questions. They truly made me feel heard and valued during my experience, focusing solely on my needs and the health safety of my delivery. So they made us feel extremely supported. Again, this is feedback from when we talk about the TeamBirth huddles, the shared planning board. These are questions that we ask, and then they respond to they give these qualitative comments at the end. You can go ahead and advance to the next slide, please. I won't read all of these, but there's one, the bottom right corner. This particular patient left this feedback, which was awesome communication in huddles. Truly helped me through some emotional upheavals, and she felt empowered that she made good decisions. I loved reading that and hearing that. And I guess the final thing that I really want to drive home is whenever you do equity work, you have to hear feedback from the patients. You have to fully understand their experience and the impact of care that they received. And so this is how we have deployed that through the TeamBirth strategy. I'll leave these comments. They are going to be sent to you in the follow-up email if you desire to read them or share them with your teams, but I wanted to give these to you. If you wouldn't mind advancing to the next slide. This is the end. And I would love to pause if we have time. And I'm not 100% sure, Audra, if I went over, if we're still good for questions and Q&A. If not.
We are still good. And we have a couple of questions in.
Oh, wonderful. I have not been looking at any of the chat. So
well, I'll read the first one that I see, and then I'll continue to look and see if I see another. But there was a question about the overlap between TeamBirth methods and Team Steps training, if you have any comments related to that.
I do, absolutely, because I've been through both. The difference really high level between TeamBirth and Team Steps is team steps is communication among the clinical team. So it's how do we improve that interaction between nurse, provider, midwife, but it still leaves out that critical piece of involving and including our patients. And that's how TeamBirth really differs from team steps, because instead of having those conversations among the clinical team, we're now taking them to the bedside and we're providing transparency and really visibility in the care that we're providing for this particular person. I see, Marianne, you have your hand raised. Would it be okay if I pivot over to you?
Yeah, so thank you so much. And thank you for this wonderful presentation, the research that you're doing. My question has to do back on the trial results. You said 90% of clinicians would recommend this. The 10%, did you happen to know why the 10% would not recommend it?
Yeah, no, definitely. And that's a great question. We actually spent a lot of time in that pilot trial with focus groups and interviews, really understanding, and we spent even more time interviewing those that we would maybe consider resistors. There's not any one individual theme that came out. There's a litany, but maybe one of the most common and recurring themes that we heard is that I'm already an excellent communicator, and so therefore I do not need to do this. We hear that really in every state, every hospital that we've implemented. So it's that, it's also timing. Providers, there were some that were very resistant to changing how, and we slow ourselves down to take the time to really bring the patients along in their birth journey, and knowing that it would change the amount of time that we're spending together. What we did find is from providers that were really open to the TeamBirth method, they often reported that it actually saved them time by doing more comprehensive conversations as a care team, having the patient, their family, and the nursing staff fully understand what the plan of care is and what the goals are. It decreased the number of phone calls that they got throughout the day or throughout the night because we were establishing great clarity from the beginning. So with that being said, there's a litany, but those are kind of the common themes that we heard. The resistors were not always so willing to continue going, and so therefore they may not have always seen that benefit, and that's some of the feedback that we received as well.
Thank you.
That's terrific. There was also a comment that was answered in the chat, and that was, are the surveys available in a variety of languages? And Lindsey already responded that they are. I wanted to make sure everyone heard that, yes, TeamBirth works with hospital teams to translate surveys into the necessary language based on their patient population. So that's great to hear. There's also a question in the chat. Is there a modified version for those black-white areas you referenced, such as stat C-section? Anecdotally, a lot of birth trauma can stem from emergent decisions that are made without what a patient perceived as consent.
So, right,
Uh-oh. Is that Trisha's connection or?
I think Trisha froze, yeah.
Okay, I'll hop in for a second. And actually, if we could go back one slide, because there is a quote that kind of demonstrates this a little bit. First, to kind of answer the question, there is not a modified version specifically for those more black and white decisions, but I think what TeamBirth does is it creates the opportunity for the conversation. So it's the quote that's in the top right corner there, and just talking about how having a huddle conversation made the difference between a traumatizing repeat cesarean and a healing one. So what was felt by this patient and expressed in some further words, this quote is cut down a bit, was that even just having that conversation and better understanding why a decision was made transformed what could have been a traumatizing cesarean experience into one that felt good to the patient.
That's helpful, thank you. And there was also a question, do you have any information about the results by provider type? Was this midwife, physician? And did you have any information about the presence of a doula?
We currently, we are not able to disaggregate the data by provider type. So it's nursing staff or providers, or implementation team and providers. that would be something that we can look into in the future, or if specific sites are interested in disaggregating that data, that's something that we would be able to modify our surveys to be able to do. It was not done in that pilot trial. And then the presence of a doula is something that we are very interested in exploring as well. It's something that patients will write comments about. It's also something that we take note of when we are implementing at certain sites, which ones have doula care already integrated into their model. And oftentimes we've interviewed a few doulas too, who have been part of the TeamBirth implementation, who really love TeamBirth and are often the ones that kind of take ownership over writing on the shared planning board and using that to help capture the birth story for their patients. So we have worked with doulas. They do often tend to be big supporters of TeamBirth and kind of fall into the TeamBirth core behaviors quite seamlessly and tend to be some of our biggest champions at sites. But we have not collected data on that thus far.
Well, I want to say thank you to you both for your presentation. It's always fantastic and always wonderful to hear. And congratulations, not only on the publications, but the relationship with Oklahoma. I think that's terrific. And it's exciting to know that 10 of our hospitals here in Massachusetts will be working with TeamBirth. So applause in the audience we see. And so I just want to say thank you again. As you guys can see, there's a QR code here that if you were to click on that QR code, you get to see a 5-minute video on why TeamBirth. So, and these slides will be made available to you guys also on the PinQuin website as usual. And the TeamBirth video is also in the chat. All right, we're going to move forward into talking a little bit about creating equity goals. And so if many of you, if you go to the next slide, have said in the poll that what you're working on is forming your equity team, which becomes very important because with that leadership support, there are sort of 8 steps to organizational change. And we know that moving forward with introducing a maternal equity bundle within your organization is an institutional and organizational change. There are equity initiatives that have been happening across Massachusetts and across the country in various L&Ds. But what we've done here is wanted to put together some very practical steps as a tool for hospital teams to think about what steps to take moving forward. This is adapted from John Cotter. Many of you who are in in Massachusetts and the Boston and Harvard community have all heard about John Cotter's 8 steps for leading change. And these have been adapted in various ways. And really, what was nice to see is that as we thought about using these 8 steps to help guide teams as well, and we've given this as a tool within the equity webinars that are available on the PinQuin and PQI websites. We also noticed that IHI also uses an adapted version of John Cotter's 8 steps, as they also push to support teams in adapting change toward equity. And so the first is that of establishing a sense of urgency. And what that means is leadership buy-in. So as teams are working to create their equity teams, having that leadership support and leadership buy-in to move in that direction, is so very important. When you form your very, very powerful guiding coalition, that is your equity team or your work group. And you want to include your nursing leads, physician leads, hospital department DEI leads, risk management, marketing, staffing, and of course, students. We have to continue to train our future and continue to train those who will be working on this long after we have ceased to work on this area. So it's important to continue to add students there. And what's missing from this slide and missing from number 2 is the part that's also very important, and that is having community representation, making sure that we have the community that we serve, someone representing those groups that are most affected by poor outcomes and maternal outcomes that are stratified by all the different versions of race, ethnicity, language, geography that you can see. And it's nice to have that representation on your equity team. From there, you'll then move into creating your equity goals, creating a vision. And so that's the 3rd step, is creating that vision. And the vision has to be one that's also shared. And so as we create these SMART aim statements to define equity goals, create a driver diagram with that SMART aim statement for equity. With that, you'll see your drivers and your change concepts. You can also put that into a fishbone diagram, but that's creating the vision and sharing that, really communicating that to your staff. And so everyone knows what direction the department is going in when it comes to maternal equity. And then here, when communicating that vision, tools for communication include your anti-racism statement. You also include communicating those change concepts. It also includes demonstrating and posting that SMART aim for equity. We're also working to communicate the vision toward equity and respectful care, not only through the presentations we're giving, but on your units, training the providers in bias and respectful care. We are continuing into this year with continued training for Speak Up Against Racism. So there's continues to be opportunity and access to train your staff in bias and respectful care through the Speak Up program sponsored by the Institute for Perinatal Quality and Improvement, or PQI. Also, communicate your racial equity goals visibly on your unit, and what that looks like varies for different groups, but that becomes really important, especially in those spaces and places where you have transition and turnover, like at shift change, where the nurses will have shift change conversations, or where your physician groups have shift change conversations. So we're just presenting the first 4 of these 8 steps. We'll present the other steps over time, but wanted to make sure that we really underscored that importance of establishing a sense of urgency by having that leadership buy-in, so that you could form your equity teams, which would be your powerful guiding coalition. Go to the next slide. And here, of course, we can't have a webinar without really giving some ode and honor to our very own Dr. Ron Iverson, who really helped us in thinking about how we create our improvement teams and using this concept of CAST. So who is our champion? We've asked everyone as you register for the maternal equity bundle or any bundle to list your champion. This is the individual who believes in the change, but also may or may not have authority to move the change forward. So having that leadership is important, but the champion is the person who's present and helping to move the work forward. Having an agent, someone who's responsible for also implementing the change, a sponsor, an individual with authority who can express, model, or reinforce, and that becomes that leadership we're talking about. And then targets, having the individual on the team who is going to be recipient of what the change is and what's happening. And so CAST is a mnemonic we use to help think about who's on your improvement team. And hopefully this will help guide your thinking on who you can include on your equity teams as you're working there. Thanks, Ron. We'll go to the next slide. And we'll turn it over to our project manager, our very own Kaylee Vitek, who keeps us moving in the right direction as she gives wrap up and announcements. Thanks, Kaylee.
Thank you, Audra, and thank you, Lindsey and Trisha, for your awesome presentation today. So with our last few minutes, I'm just going to provide a couple reminders and announcements. So this was the first of our year-long monthly equity webinar series. The next one is on November 15th. We'll be discussing equity teaming. And coming soon, Claire, our project coordinator, and I are hard at work securing continuing education, CME, CEU, and social work credits for the recordings of these webinars. So we'll let you know when access instructions for those are available. A reminder, we saw the map earlier in the webinar of those 15 hospitals who have onboarded for the equity bundle. If you haven't formally joined yet and would like to, there is an onboarding form on our website, and Claire will put that in the chat. If you've come today and want to join us for the rest of this ride, just complete your team roster and you'll be signed up for all of our emails, reminders, and additional details. Another reminder, we do have an equity bundle readiness assessment survey. It's just a really brief survey. We use it internally just to see kind of where hospitals are who are joining us for this bundle, but we also encourage you to use it as an internal tool to see where you are in this process, kind of assess your strengths, your weaknesses as you start this bundle journey, and where you might want to focus your resources. So that is also coming into the chat for you by Claire. Another reminder, we mentioned Speak Up Champions training. There is another free training for Massachusetts providers happening on December 17th and 14th, 2022. Continuing education is available. The registration link is coming to you in the chat, or you can also snap the QR code that's on this slide. And again, these slides will be posted on our website for you. And now a message from our partners at March of Dimes. November is Prematurity Awareness Month. So there will be several buildings in Boston who will be lighting up purple on November 30th to mark the end of Prematurity Awareness Month. And then we encourage you to wear purple on November 17th. And then if you are a social media user, please tag March of Dimes and use the hashtags for prematurity awareness to help spread the word. Another resource that we have available for you with our partners at the Institute for Perinatal Quality Improvement is another equity webinar series that we did earlier this year. These were created to help you complete your structure measures. So that data that we reviewed in the beginning and where you answered the poll about, which structure measure you were working on implementing, there's likely a webinar in this archive that can help provide some guidance for how to put those structures in place at your hospital. So again, Claire will be linking to these webinar recordings in the chat, and they are available on our website. And another resource we have available is if you joined us for one of our previous bundle webinar series on OB hemorrhage or severe hypertension, or if you'd like to watch those webinars for the first time, we have them available for CE credits as well through Boston University. So Claire will be putting the links in the chat to each bundle webpage. The passwords are here, and just follow the instructions on the page to claim credits. And you can claim credits if you attended those webinars live in 2021 for hemorrhage and in 2022 for hypertension, or if you're watching them for the first time. So if you joined us for any of those, we encourage you to take advantage. These credits are free. And with that, I'll turn it back to Audra, but thank you all so much for joining. It was awesome to see our turnout today, and we look forward to next month.
Yeah, it's always great to give a little bit of time back to everyone. We just have a few minutes left in the hour for the breaks we all need before we go into our next step in the day. But if there's any questions, don't hesitate to reach out. I want to say thank you again to Kaylee, as always, who makes most of this move forward and happen. And thank you to our leadership from Dr. Jop, as always, as well. But that being said, there's a comment in the chat. Just want to make sure it's not a question we can answer here. And then there's a wrap-up comment from Claire. Oh, Trish answered Marianne in saying that in the pilot trial, they tracked nurse turnover metrics, and at the facility, they saw a reduction. In addition, empowering the voice of the birthing person also grows and empowers the voice of the nurse. Decisions are now being made collectively as a team, which decreases the role of the nurse being the mediator caught in the middle. However, the impact of the global pandemic and the national nursing shortages, we're no longer collecting that metric with institutions, as it would be difficult. So there was a question in the chat from Marianne that this is Trisha's answer for it. So you guys have that as well. Thanks, everybody. Good to have you all. And we will see you next month on the third Tuesday at noon.
Yeah. And for everybody, the links that Claire shared in the chat today will also be provided in a follow-up email. So if you didn't catch all of them, I know there are a lot, they'll be provided to you. Thank you.
All right. Have a great afternoon.
Thanks, everyone.